Hello everyone. In this series of videos, I am talking to you about how to remove the Foley urethral catheter in a male. In my first video, I spoke to you about having a checklist, which is essentially a 3x3 checklist, meaning thereby 3 questions and in each 3 sub-questions. And this checklist was targeted towards meeting 3 objectives. Firstly, whether the catheter has served its all purpose. Secondly, if I remove the catheter, it will not harm the patient. And thirdly, if I have to reinsert the catheter, am I capable and am I equipped to reinsert the catheter? And in this particular video, I touch upon some important points to take care while you remove the catheter from patient's genitalia. First of all, if you are a paramedical person and you are going to remove the catheter, never remove a urethral catheter without getting the go-ahead instruction from the doctor. And preferably, you should have a written instruction from the doctor, and then you must take the consent also from the patient. The first precaution to follow is that the patient must be lying down on a couch or on a bed in a supine position. Never remove a catheter from a patient who is standing or even sitting, because in some patients this can precipitate a vasovagal attack and patient may faint. And you do not know in which patient the catheter removal will be painful and in which patient it will not be. So make it a general practice. Put the patient supine in the bed and then properly clean the genitalia and drape the genitalia in the manner shown here with a sterile sheet. The second precaution to follow is that you put underneath the tip of the penis a pad, and I'll tell you why this is needed later. The third thing to do is to attach a syringe with the balloon valve, and you should push the tip of the syringe properly and twist just to ensure that you have actually deactivated the valve, and then you slowly aspirate. Now sometimes the patient knows the amount of fluid present in his balloon, or it is written over the Foley catheter that how much fluid was filled in the balloon. But in some situations you will not know this thing, and you should aspirate therefore till you are kind of creating the vacuum effect in the balloon channel. Here you aspirated about how much, 20 cc, right? Now this is a patient who has undergone transurethral resection and his catheter is being removed. So here sometimes we put in large volume of fluid. And now if you emptied the balloon completely and when you maintain further suction, as you can see here, the balloon channel is collapsing. This is the indicator that you have deflated the balloon completely. Now after that, what you should do is, in some patients, particularly those who have undergone operation on the urinary tract, to re-inflate the balloon by 1 cc of the fluid, as I have done here. Why? I'll explain you a little later. The precaution when you pull the catheter out is that you be extremely slow and gentle and tell the patient that I'm going to remove your catheter. You will have an experience of something being pulled out. Some patients complain of pain here. Now, as you are about to deliver the catheter, keep this pad below the penis tip and see here the catheter that has emerged out. Look at the balloon which is slightly inflated, and then there's a mucus clot over the balloon. And as you take the tip out, in some patients the urine drops out of this Foley catheter, or a blood drops, or some mucus drops. And if you do not keep the gauze piece below the penis or a pad below the penis, then the urine from the catheter will drip out and will stay in the patient's garments or the couch sheet or any such thing. So it is better to, one, protect this kind of spillage of infected urine, and then if you have this pad and you stain this pad with the urine, you can show this stain to the doctor of the patient that this kind of urine came out from the tip of the catheter. You can take a picture of this pad and share with the senior consultants if required. Then I told you that after completely deflating the balloon, re-inflate the balloon by 1 cc of fluid before you start pulling it out. Why I want you to do this kind of thing is that just look at here. If you deflate the balloon completely, then a certain amount of folds result on the catheter, as you see here. These ridges are created on the balloon wall, and this is because of the memory of the balloon wall. And this is more common in silicone catheters. And this is more common if you inflate the balloon more than 10-15 cc. Now, if you have these ridges on a catheter and you pull out this catheter, these ridges can sometimes abrade the prostatic fossa or the apex of the prostate or a healing urethra following urethroplasty. So in all post-operative cases, this precaution of re-inflating the balloon is recommended. There's no harm if you do it in every patient because removal of a slightly inflated balloon is less painful to the patient. Next thing to do is to cut the tip of the catheter and take this in a sterile bottle for culture and sensitivity. Now, to make this step easy and to make this step simple, I advise you to place a sterile sheath around the patient's genitalia. Otherwise, cutting the tip of the catheter and correcting this cut tip becomes slightly messy. You should also know about one more fact that in some patients, rather than this catheter cuffing, which I just showed you, the ridges that are created on the balloon wall, the entire balloon wall can fold over the other. And this phenomenon is called creeping of the balloon wall. And this then creates a bigger circumferential ridge all around the catheter. And then when you pull out this catheter, it is sometimes more painful and sometimes more abrasive. Then after removing the catheter, you must inspect the external urinary meatus and make a record of this in patient documents. You may sometimes see an edematous lip of the meatus as shown in the picture A. This edematous meatus leads to spraying of urine and some pain at the tip of the penis at the time of passing urine. So if you see such a thing, tell the patient upfront. In the picture B, you will notice that the meatus is all yellow, purulent, and there's an adjacent area which is inflamed. Now this is a little more serious problem. Here, the patient can develop difficulty in passing urine, more pain in passing urine, and this may even end up in meatal stenosis later on. So you tell the patient that if you notice thinning of the urinary stream, please come back and we'll tell you how to manage this urinary meatus. The third picture is C, where you see meatus ulcerated because of the pressure of the catheter shaft on the lateral edge of the meatus, and then one side of meatus is fine, the other side of meatus is not fine. So patient will have some or other problem, even bleeding from the meatus subsequently. So it's a good idea and it's a good practice to make a note of the condition of the meatus and the glans penis and tell the patient what he's going to expect. So I hope you understood the steps of the removal of the catheter. And in case you have any questions or comments about it, please write to me on my email. Thanks very much.